Hi, this is Jean Deschamps from Université Montréal. This video is part of our technical series and regards quality image acquisition, as well as probe orientation and optimization. This is an updated version based on our previous work with Alberto Sono. At the end of the video, you will be able to understand the different exam types, understand the probe orientation based on the type of study, and understand how to optimize the settings for standardized acquisition. There are 5 main things that you need to look at when you're doing quality image acquisition. The first one is profile, the second is orientation, the third one is depth, angle, and finally gain. When selecting a transducer, you will often have the option to select the profile for the transducer you are selecting. In older machines, this may not be apparent immediately, and the probe selects the profile automatically. In these instances, a button like Exam will allow you to make the changes. A profile represents a set of image acquisition and optimization dedicated to a specific utility. These include transducer frequency, gray profile, tissue exclusion, and harmonics. For a general user, knowledge of these is not typically necessary. Selecting the appropriate profile is the only thing that matters. Notice here that the two profiles have vastly different characteristics, such as different gray differentiation, frame per seconds, and others. The two profiles most commonly used will be the cardiac setting and the abdominal settings for non-vascular use. Some machines have additional profiles such as lung or beeline. These can be used for these specific instances. You have to start by recognizing the different elements on your screen. These include the obvious and important depth measurements, but includes as well the orientation marker and the focus point. The orientation marker is a critical point to be aware of. Ultrasound really requires an understanding of different cut planes as it provides a 2D image of a 3D structure. This is quite similar to a CT scan cut, and operators familiar with those may use this knowledge to figure out where structures are in comparison. The 3 main planes are thus the frontal or coronal plane, the sagittal plane, and the transverse plane. As we talked about, the orientation marker is a critical thing to recognize. In non-cardiac application, this orientation marker is located to the left of the screen. In many standardized non-cardiac applications, this will also correspond to either the head or the left of the patient. The probe will then be aligned in consequence. Cardiac evaluation utilizes multiple standardized views, as do all ultrasonic applications. However, compared to other applications, we usually work along a single cut plane. Cardiac ultrasound rotates in multiple planes. To add insult to injury, the cardiac convention has the orientation marker on the right of the screen, and the LV apex is on the right of the screen in the apical 4-chamber view. This essentially has no consequence on a day-to-day basis, but will require a reversal of the probe if the profile is not switched to a cardiac one. Practically, for cardiac applications, the marker switch is irrelevant as the views are standardized without a direction of probe marker in mind, and usually leads to little confusion if you know what you're looking at and you know your usual views. The abdominal orientation is generally going to be a coronal cut. The probe marker should be directed towards the head of the patient. The screen marker will be by convention on the left, as the machine should be in the abdominal profile. The pulmonary orientation is generally going to be a coronal cut. The probe marker should be directed towards the head of the patient. The screen marker will be by convention on the left, as the machine should be in the abdominal setting. However, it is also possible to perform a transverse or axial cut either in the anterior or posterior thorax. There is no established convention as to which side of the patient the probe marker should be put in the axial cut. We suggest that the probe marker be aligned with the same side as the screen marker, hence left. In our opinion, this makes more sense as ultrasound machines are usually set up towards the head of the patient with the screen facing their feet. In this setup, the marker on the screen is towards the patient's right, and thus the probe marker should be directed similarly. The posterior pulmonary orientation is generally going to be a coronal cut. The probe marker should be directed towards the head of the patient. The screen marker will be by convention on the left, as the machine should be in the abdominal profile. One of the most common mistakes early on is to improperly approach depth in ultrasonographic imaging. An inappropriate depth at a specific moment of the exam has ramifications that extend from missing important findings to suboptimal image quality. First, try to start with more depth than you believe necessary for the exam. it is quite frequent that a too shallow depth may miss important findings. Classically, a pleural pericardial effusion may be missed on a parasternal long axis view of the cardiac exam. Indeed, starting with a deep image on that view is part of the standard image acquisition sequence in some labs. Only after this should you optimize the image so that it is centered and occupies most of the screen. The cardiac view depends very highly on the location of the assessment, given its multiple potential windows and views. A specific standard for depth is thus hard to give, as it varies between views and body habitus. In the anterior pulmonary view, the depth is generally 6 to 10 centimeters. However, in specific instances, when examining the pleural lining, decreasing the view to frame it can enhance temporal and spatial resolution significantly. In the posterior pulmonary view, in general, the standard view is between 12 to 18 centimeters for most patients. In general, one wants to have the spine visible within the frame and providing the lower border of the image. In the abdominal region, the general standard is between 10 to 20 centimeters, and usually is going to be more in the 15 to 20 in most patients. It should really just be deep enough to see all the structures of interest. The focal point is the convergence of ultrasound beams and is intrinsic to the actual transducer. As we said, the pulse beam can be narrowed and focused to improve lateral resolution. This focal point can be adjusted to some extent in specific machines, transducers, and profiles. Its location depends on the frequency of the transducer. A high-frequency transducer tends to have a natural focal point at equidistance between the transducer and the depth. A low-frequency transducer has a natural focal point closer to the transducer. The lateral resolution is best and increased up to the focal point or region. Past it, there is significant divergence of the beam, and lateral resolution decreases rapidly. There is a trade-off to be made between resolution and depth in the near field. Where it becomes interesting is depending on what probe you're using, you might be able to adjust your focal point. By default, the focal point will be placed differently if the depth has changed. The focus or focal point represents the point at which the ultrasound beam is the narrowest and where point-to-point distinction is best. The focal point, though, may be adjusted, as seen in the above images. Attempt to put the focus point on part of the image that you're more interested in and requires an attention to detail. This specific case is a pleural lining assessment performed using an abdominal probe. On the left of the screen, you can see a marker along the depth scale that reflects where the focus point is. This is improperly placed and will decrease its sensitivity to pick up sliding as well as potentially hide artifacts emanating from the pleural lining. On the right is the same patient at the same location within minutes. The focal point was adjusted at the pleural lining. Notice how we now have a better view of the pleural sliding and the vertical lines or B lines that are now present, reflecting underlying paracardial pathology. The vertical or B lines were present on the image at left, but they were certainly less apparent. Finally, you need to start thinking about using maneuvers to frame the image you're looking at and get the standardized view. This can be done using maneuvers that are detailed in our transducer manipulation video. Framing requires using different maneuvers, specifically usually a combination of sweeping, sliding, and fanning and rocking to center the image upon the point of interest. This in effect is used in combination with depth to ensure the region of interest is framed appropriately. The motion used in this clip is rocking, as described in a transducer manipulation video. It is moving, essentially in this case, the heart in the same plane as the ultrasound beam and not actually showing us new structures as much as just displacing the ones that are being caught by this specific beam. Using these techniques, one can optimize the visualization of structures in a very effective way. Finally, we have to talk about gain and how to properly display on the screen the image that you're looking to get. The gain is essentially the volume of the signal. The ultrasound receives a specific amount of signal independent of any image manipulation performed on the screen in standard settings. The relative intensities of each region pulsed makes up the gray mapping of the 2D image. All these intensities can be increased, keeping the relative differences between each of them. This makes the signal brighter or darker. You'll notice that overgaining or undergaining can lead to loss of signal differentiation on the screen. Areas will appear uniformly white or black in these situations, similar to over or underexposure in photography. This is due to the limited ability of the screen to display extremes of amplified signals. The relative gains, depending on the depth, can be adjusted individually. This is called time gain compensation. The ultrasound will selectively intensify or decrease signal coming after a specific time post-pulse, which corresponds to a specific depth. This is of particular importance as the signal return decreases as it comes back from deeper tissue and may need to be intensified to match the rest of the image. A lot of machines have some degree of time gain compensation already in place, but you can certainly manually adjust it further if you need more. Lastly, we'll just talk quickly about taking clips and still images. This is meant to be essentially a machine agnostic element here. And every machine will have a couple of essential elements. The first one will be the freeze button, which simply freezes an image on the screen. The store image activates the machine to record, depending on the setting, retrospective or perspective video clips. In most standard Echo machines, it will capture multiple seconds retrospective video clip. You must then press store to capture a still image or clip again. You can also do this with a simple image. So if you press freeze and store afterwards, it will store the image and not an actual clip. Of course, to store and save images, you then need to enter patient data and end an exam. In summary, always make sure you look at these things when you're thinking about adjusting your ultrasound to get the best image quality: profile, orientation, depth, angle, and gain. This is the end of this lecture regarding quality image acquisition. Feel free to reach to us through our Twitter accounts or at the Sono Uni website or Sonovault YouTube channel.